Now, from the theory, we have what we call a generic cognitive model. The theory applies across all conditions, whether it's just a minor type of problem that a person might have, like procrastination or losing the temper too easily, or it may go all the ways to something like schizophrenia and depression and other conditions. So the theory then can help to explain all types of psychopathology, just like anatomy and physiology can explain all of the problems that people have in their abdomen or in the rest of their body for the surgeon. Now, once you have the theory, then let's say a patient comes in and the patient has depression and anxiety and, say, panic attacks and back pain. Now, how are you as a clinician going to understand that? Well, if you know the theory, you're going to be able to get a really quick picture right away. So this is the way you would formulate it. So from the theory, you're going to be able to get a formulation of the various disorders. So you might think, well, the person has back pain and panic attacks and depression. And is there another thing?
Anxiety.
Anxiety. So you'd think as you put it together, well, first, perhaps the person had back pain, and perhaps it might have been a veteran injured his back in the war. As he gets the back pain, he tends to focus his attention on the back pain. And what happens when you focus your attention on any pain? It gets worse. So first of all, he focuses his attention on that. Then he gets the belief from that this back pain is going to get worse and worse. And so he tends then to catastrophize. So first he has the focus on body sensations, and then he has the catastrophizing, the exaggeration of the body sensation. So he gets himself into the mode of focusing on body sensations and at the same time exaggerating the meaning of the sensation. And in this particular case, this catastrophic meaning is that the back pain is going to get worse and worse. So then, let's assume that he starts moving around and so on. He starts to feel dizzy. Well, he's already in the mode of focusing on the dizziness. And as he focuses on the dizziness and starts to catastrophize about it, what condition is he going to get next? And for this, you're not going to get a prize, but you're going to get shoved out of here if you don't guess what it is.
Panic attacks, someone said.
What did somebody say?
Panic attacks.
Of course. So this isn't a big mystery when the person comes in, but if you have a model in advance, now the model, the way you apply it, just before you actually get to talk to the patient, you now have a roadmap, or you have kind of a picture to know what to look for. So then he starts to get the panic attacks. And you know he's a catastrophizer, so he starts to think, this is never going to get better. When he starts to think it's never going to get better, or let's wait before he starts to think it's never going to get better. Then, once he has the panic attacks, what's going to happen from day to day regarding panic attacks? He's going to worry that he's going to get another panic attack, isn't he? So he's going to be anxious all the time. So now you have your back pain, you have your panic attacks, you have your anxiety. Now how does depression come into it?
I'm never going to get better.
Right. So with this conceptual model, you get a picture of the entire disorder. Now, we don't know with an individual case whether it's going to fit specifically that pattern, so then you have to look at the individual case and you find out that this person, let's say, has been in combat, and maybe in this particular case he has flashbacks and has a lot of worries about that particular thing. And then as his back pain develops and increases and so on, he starts to think more and more of how things getting worse and worse. So then you make your own case formulation.